I first wanted to say, I don't know if anybody else noticed in Anna's talk, one of the journals in a reference that she cited was called Immunological Speculations. I would like to co-opt that and rename my talk Immunological Speculations. I will be giving an update from our working group, which started tackling donor-derived cell-free DNA. These are my disclosures. I first wanted to start with the theme that you heard from other speakers, which is reminding us what characteristics of tests need to be established in order to determine that they're actually worthwhile to do in our patients. These performance characteristics are called analytic validity, clinical validity, and clinical utility. If I could advance, can you switch it back away from the presenter mode, please? Thank you. So analytic validity or technical validity refers to how accurately and reproducibly a test detects or measures an analyte. Clinical validity is how well the detection and measurement of that analyte predicts or identifies the presence of a disease or a clinical health status. And clinical utility then is the last step, and clinical utility judges whether the test, its accurate and reproducible measurement, and its correlation with a disease actually improves health outcomes because of subsequent intervention that is prompted by that test result. So each of these is a cog in a large working machine that determines whether a test is valuable to a patient or not. They are interrelated, but each of them is an independent requirement for a test to be valuable. And we feel for donor-derived cell-free DNA, I'm going to preempt the questions, that a lot of the field has jumped over to clinical utility, but there has not been as much attention given to analytic validity and clinical validity. And so that was the objective of our group, was to formulate guidelines and identify gaps in knowledge specifically for analytic and clinical validity of these tests. And so what we considered were the factors that could affect the reproducibility or accuracy of the test, and those included pre-analytic and analytic factors that the lab is concerned with, but also just the clinical condition and status of the patient that the provider should be aware of before ordering the test. All of these things are going to feed into whether there is any clinical utility of the test at all. So it was not our objective to look at the literature and adjudicate the clinical trials and tell you, yes, this test has value in improving outcomes in these clinical contexts. I'm not going to talk about actionability of results or recommendations for intervention. I will point you to several position and consensus statements that have been released by the major transplantation societies in support of clinical utility. But again, today I'm going to emphasize what needs to be established for analytic and clinical validity of donor-derived cell-free DNA. So I knew almost nothing about this topic when I was asked to take it on, and I'm really beholden to the expertise of the working group members that I've shown here. We put together a team of people who have expertise in histocompatibility testing, HLA laboratories, but also in clinical genomics, because these tests fit under that umbrella as well. We have also guidance from transplant pathology, as well as leaders in laboratory quality and proficiency testing, so external quality assurance, and representation from the transplant physician community, both in renal and thoracic transplantation. So thank you to everyone in this working group for sharing your expertise, and I'm simply presenting on their behalf. Cell-free DNA is a normal analyte, a normal molecular biological molecule that is present in all of us. And it's present in many bodily fluids under healthy conditions as well as disease conditions. It is predominantly originating from leukocytes, white blood cells in the blood, especially neutrophils. And the highest type of cell that's contributing cell-free DNA to the circulation that is not hematopoietic in origin is the liver, followed by the intestine. So cell-free DNA is released after different types of cell death, and its abundance is increased upon injury of the tissue. It has a normal concentration of 1 to 10 nanograms per mil in the plasma, so it's not all that rare. And it has a quite short half-life, a quick turnaround time, which is somewhere less than 2 hours. So it's actually quite dynamic, and it fluctuates under many conditions, especially those that are non-pathologic. So in studies that have looked at cell-free DNA to categorize it for the purposes of tumor-derived DNA, for example, they have shown that in healthy individuals, the inter-individual, between-individual variation in the abundance of cell-free DNA is somewhere on the order of 25 to 30%. Additionally, if you sample the same patient or person multiple times, you will see an intra-individual variation, again, of about 25%. So there is significant fluctuation under normal homeostatic conditions. And then the abundance of cell-free DNA changes with increased tissue injury associated with disease. So the premise of donor-derived cell-free DNA is that it leverages the genetic disparity between the donor organ and the recipient to detect the donor's cell-free derived DNA as a marker of tissue injury from the allograft. So it has been demonstrated to detect allograft injury, including subclinical injury, and this is because it is quite dynamic and it rises earlier than the typical lagging indicators of graft function like creatinine or BNP. It's also been shown that the levels of donor-derived cell-free DNA have some correlation of value with histopathological findings, so they are related to abnormal findings on biopsy. From the methodologic standpoint, there's actually a variety of different assays and methods that can be used to detect and measure this as an analyte. They all leverage genetic disparities or single nucleotide polymorphisms, indels, or copy number variation between the donor and the recipient. And they do this through a variety of technical methods like sequencing or digital droplet PCR. Each of these, as you can see, varies in the number of genetic disparities that are actually measured or detected between donor and recipient. It is somewhat laborious in terms of informatics because, especially with the shotgun sequencing where you're looking at genetic variants across the whole genome, there's a lot of informatics that go into deconvoluting donor and recipient. And then there's two main outputs of these assays, which are detecting and measuring donor-derived cell-free DNA. The first is fractional, and all different methods provide this, which is just a percent of donor-derived cell-free DNA among all the cell-free DNA that's in the plasma. So you have all the recipient cell-free DNA, and then the donor's derived cell-free DNA is a small component of that, some percentage. All of the methods provide this fractional or percent, and some methods can also provide an absolute quantitation or abundance of the donor-derived cell-free DNA, which is usually given in copies per mil. So these two methods of quantitation have their own pros and cons, which is important to be aware of. In this table, what I've done is I've summarized the landscape of currently available testing for donor-derived cell-free DNA. So today, if you wanted to test your patient, you would draw for a referral test and send it out to the vendor of choice for your center, and the test itself would be done in the vendor's centralized laboratory. As you can see across the columns, that each of these assays has a different number of SNPs that they interrogate between donor and recipient, uses a different technology. Some give fractional, some give absolute, as well as fractional. So there's variation even among these centralized laboratory assays. And then I think the most important source of variation among these assays is in the red box. Here I've summarized the diagnostic threshold reported by each of the vendors. So the first point here that I want you to appreciate is that if you are testing in a kidney transplant patient, the actionable or abnormal threshold for your kidney transplant patient is going to differ depending on the test that you're using. So 2 of the vendors report 1% of donor-derived cell-free DNA as abnormal. Another vendor reports 0.69%, and another is reporting 0.5%. And then when you look within a single vendor across different transplanted organ types, you also see that the reported thresholds are quite variable. And in particular, what I want you to take away is that heart and kidney thresholds are really quite low, but liver, based on the literature, the abnormal threshold is above 15%, which is like 10 times higher than the threshold for kidney. So there's obviously organ-specific variation in what is normal versus abnormal. So the top part of this table is showing you those tests that you can perform and send out to a centralized laboratory. One of the reasons that STAR really felt a push to tackle analytic validity in particular is because the vendors have moved to developing distributive kits, which means that your local laboratory could very likely take that kit, purchase it from the vendor, and then run this assay locally in a decentralized manner. None of these, as of yet, are offered in any other format except RUO, which for those non-laboratory people means research use only. And for a laboratory to adopt a research use only kit in their lab and offer it as a laboratory-developed diagnostic test, there's a lot of hurdles that they have to overcome, a lot of performance specifications they have to establish in order to meet the criteria based on CLIA, which is a federal law. So even though this is very exciting and we think that the HLA lab is the perfect place to run these tests because we also have other biomarker data like DSA that gets to the risk of rejection, it's not so easy as just purchasing a kit and then running it. There's a lot of background that has to be done before you can establish it in your lab. So the first set of recommendations that I'm going to go through is really for the labs, but the clinicians should hear this too. These are the factors that influence analytic validity or the accuracy and the reproducibility of these tests. So what we did as a group is we reviewed the technical literature for donor-derived cell-free DNA. There's more than you would think, which is good. We also reviewed new laboratory accreditation standards from ASHI, which were established for this test in 2024. And we looked at the clinical trials, the major ones, not with an eye to clinical utility, like is the test valuable, does it change outcomes, but actually really focusing on the data where they establish the performance specifications of these tests. So there's separate publications from DART, for example, just really focusing on their stable transplant patients and the dynamics of this analyte in that population. Those data are really critical for determining the performance specifications of the test. So overall, there's a number of pre-analytic factors, even down to the type of tube you collect the blood in, that appear to affect the sensitivity and specificity of this test. Then you have biological variables, which are predominantly that it is quite variable in normal circumstances, even in everyday healthy people. That goes into determining your reference ranges, and your reference ranges go into determining the actionable threshold. So we also looked at data both using a population-based universal cutoff, similar to what the vendors are using. So you can send one test, your patient has a value of 2%, you say, oh, that's over the actionable threshold of 1%, it's abnormal, versus those that use serial measurements and establish changes from an individual's baseline to determine what's abnormal. So here I'm just quickly summarizing at a high level the pre-analytic factors and methodology selection that the lab needs to consider in this test. One of the key ones actually is turnaround time when you're looking at methodology selection. So typically this test is used as a sequential testing. So there is perhaps graft dysfunction, and instead of doing a biopsy, the provider sends donor-derived cell-free DNA. If that's abnormal, then they have to waterfall down to a biopsy to arrive at a final result. And so if your turnaround time is a week, and this is predominantly for cause testing, that is not going to serve your patient population. So in terms of methodology selection, you really have to think about how quickly is your provider going to need the result. Additionally, there's variation across methodology in terms of the upper limit of quantitation and the lower limit of quantitation. So if you're predominantly going to be testing thoracic transplant patients, the abnormal thresholds there in that table I showed you are like 0.5%. That's exceedingly low. So you need a method that's going to be able to achieve that lower limit of quantitation. But if you're going to be testing liver transplant patients, then your abnormal threshold is 20%. Some assays have like a ceiling of upper limit of quantitation. So if your patient population could have values in excess of 50%, some of these platforms are not going to serve that patient population. We also, as a consensus, felt there is currently no data on whether these different assay platforms can be used interchangeably. There's a lot of data on one assay in one transplant patient population, but very little data comparing the platforms. And then, of course, we're really lacking in cost-benefit and cost-effectiveness analyses. There's a lot of assumptions being made that it would be better to do surveillance testing than protocol biopsies, but there's really not in existence cost-benefit analyses as of yet. A second point that I wanted to make is really to show you the data from these clinical trials of the stable transplant patients so you can visualize the degree of variation in otherwise normal patients. So we have renal transplant patients from DART, we have heart transplant patients in the middle from the DOAR clinical trial, and then we have lung transplant patients on the far right side. And these are all normal patients tested serially over time. So each line is a single patient. So if you compare the lines, then you compare the inter-individual variability. And then the height of each line is actually the variability over time in a stable patient. So you can see that there's both within individual variability, of 25 to 35%, and then between subject variation of up to 50%. So even though the abnormal threshold may be drawn at 0.5%, a large number of stable patients will actually exceed that just under normal circumstances. One of the major factors that we found that is likely contributing to this intra-individual variation is time post-transplant. So there's a number of studies, again, from kidney, heart, and lung, all showing that when you serially monitor patients over the course of their post-transplant period, you find significant variation as a function of time. In particular, the first 1 week to 1 month post-transplant donor-derived cell-free DNA, whether you measure it by copies per mil or by percent, is very high, just as a function probably of being post-transplant, post-IRI, post-surgical trauma. And this is true across different organ types. It seems probably like a conservative cutoff would be somewhere after 2 months to 3 months post-transplant is when you start to achieve this low-level baseline. Post-transplant dynamics also become very important in the late post-transplant period. So there's this very nice study that was published in Clinical Chemistry where they showed that when they followed renal transplant patients, 300 of them who were stable over time, they saw this trend upwards after about 3 to 5 years post-transplant in all of those patients, which was not supported by histological or laboratory measures of graft function. And so the percent of donor-derived cell-free DNA was going up almost universally. But when they looked quantitatively, the abundance of donor-derived cell-free DNA was not changing, which suggests that the percent is being confounded by some factor. And in fact, what they saw was that the total cell-free DNA, so the denominator that goes into the percent of donor-derived cell-free DNA, was going down. And this is because the recipient's white blood cell count was going down. So if total cell-free DNA is deriving mostly from the recipient's white blood cells, And over time, with extended exposure to immunosuppression, patients become leukopenic, then the percent of your donor-derived cell-free DNA is going to go up because your denominator is going down. This, I felt, was very convincing in showing that there are other confounders that go into this value that have nothing to do with the allograft status itself. Another significant confounder is the effective donor mass. So if you're looking at either the total donor-derived cell-free DNA or the percent of the total, if you have more donor organ, you probably have more donor-derived cell-free DNA. And in fact, in several studies, this seems to be true. So in the Alamo trial, the blue box plots are recipients of a bilateral lung transplant, and in red are the recipients of a single lung transplant, and these are all stable patients. You can see the blue bilateral lung transplant recipients just have more donor-derived cell-free DNA, so you get 2 lungs, more donor-derived cell-free DNA than if you get 1 lung. And this same concept was shown in another publication where they took it a step further, and they tried to propose that there should maybe be an adjustment for the donor organ size. So this table is showing the odds, the abnormal threshold in single lung transplant recipients versus double lung transplant recipients for correlation with AMR and ACR. So I've highlighted AMR in yellow, and you might not be able to see it because it's quite small, but basically for a single lung transplant patient, they're saying 1% should be the threshold, but for a double lung transplant patient, it should be over 2%. The same concept actually was shown in a small study of pediatric kidney transplant patients where donor-recipient size mismatch is a factor. And what they did is they broke out their cohort into patients who received a donor kidney that was relatively well size matched to the child versus those that received, say, an adult kidney where the donor's body mass was much larger than the child's. And what they showed actually was that not unexpectedly, but still important to demonstrate that the children who received a kidney from an individual who was much larger than them just had a higher baseline of donor-derived cell-free DNA than the pediatric recipients of a size-matched kidney. So this leads to our recommendations in terms of considering performance specifications, is that there are significant fluctuations over time post-transplant, and in particular these like intervals, very early post-transplant and then again late post-transplant, that may need to have their own thresholds determined because of the fluctuations over time. Certainly the data is in strong support of organ-specific thresholds that are needed, especially if using population-based abnormal cutoffs. The data also seem to support the need for some kind of correction value for donor organ mass, although this needs a lot more data to determine exactly what's appropriate in these various settings and patient populations. And that leads to the final recommendation, which is, remember, not all patient populations have been validated. Pediatrics in particular needs a lot more data than what exists. And so individual change factor may be more informative in a patient population that has been understudied than relying on a universal threshold that was based on a patient population which is actually not analogous to your patient. We would also, our final recommendation for the laboratory is to remember there are no external quality assurance programs currently in place for these assays because they have been performed in centralized labs. We reviewed the literature on external quality assurance for a similar clinical modality, which is non-invasive prenatal testing. This is also cell-free DNA based and looks at genetic disparities between the fetus and the mother to make determinations of fetal health and fetal size. There was a publication in 2023 where they described their attempts to establish an external quality assurance program, and basically their conclusion was the lab values that they were getting were really variable, and the type of reference material that was being sent out seemed to be a significant factor. It was difficult to find an artificial mix, and so they had to rely on clinical samples, which were difficult to come by, and the quantities that you need to send out to a bunch of labs. So we feel that this is a really important point to think about for our field, because unlike serum creatinine, which is standardized nationally such that the value that one lab gets is translatable to the value another lab gets, there is no standardization of these assays across laboratories at this time. So we need to develop external quality assurance or proficiency testing programs. And until then, laboratories that are doing these assays in-house will have to develop their own plan for quality assurance, which includes selection of the appropriate reference material and probably comparison with the central vendor laboratory because there's really no one else to compare with. So external quality assurance programs should carefully consider the appropriate testing material, which should really probably be true clinical specimens. Okay, so the second part I'm going to run through is recommendations for establishing clinical validity, which is the relevance of the analyte to the clinical condition. And this is really for the providers to be aware of. The literature shows that there are many causes of elevated cell-free DNA that are not rejection. The time post-transplant data suggests that ischemia, reperfusion injury, and surgical trauma are a significant factor in increasing cell-free DNA. There are case reports and small studies showing that if you test for cell-free DNA very shortly after you've biopsied, it will be elevated, and that is likely due to mechanical injury of the graft. CNI toxicity in the case of renal transplantation can cause tissue injury. And one thing that we're very concerned about is the confounding clinical condition of infection. If it is systemic, then you will get possibly leukocytosis in the recipient, which is going to increase total cell-free DNA. If there is graft infection, then you're going to get an increase in donor-derived cell-free DNA in the graft due to injury that is not rejection. There are other probably rare circumstances where you also have changes in donor-derived cell-free DNA that have nothing to do with rejection. So there are these unreliable clinical scenarios where testing for donor-derived cell-free DNA to look for rejection is probably not indicated. And again, this is because of the sensitivity of the donor fraction, which is affected by the recipient's cell-free DNA abundance. So leukocytosis or recent blood product exposure, plasmapheresis, plasma exchange, or leukocyte depletion. All of these normal interventions in the transplant context can affect the measurement of donor-derived cell-free DNA in a way that is not related to allograft status whatsoever. There's also a strong feeling among our group that when you have a known viral, bacterial, or fungal infection, that you are not going to be able to detect rejection using this assay. And again, a reminder that when you're repeatedly measuring, if you've just recently biopsied, it could be elevated because you injured the graft. There are a lot of studies coming out that are really quite convincing that donor-derived cell-free DNA at the population level is elevated during rejection compared with stable conditions. However, we want to emphasize that there is, at the individual level, substantial overlap in the spread of values between rejectors and non-rejectors. And in this very nice study in Nature Medicine in 2024, what you can see is that even though overall, the trend of donor-derived cell-free DNA is going up among these different forms of allograft injury, there is still substantial overlap and spread between these different etiologies of rejection. And in some cases of chronic or progressive injury like IFTA, there is no change whatsoever. So the donor-derived cell-free DNA is not necessarily indicative of allograft status in that case. So this leads to a very good negative predictive value of a rule out for rejection, but a much poorer positive predictive value. And so what we want to emphasize is that actually similar to non-invasive prenatal testing, donor-derived cell-free DNA on its own is not independently diagnostic of rejection. It requires adjunctive or parallel testing, especially a biopsy for the final diagnosis. So these are just our recommendations summarizing what I've showed you is that there are interventions and common clinical scenarios in the transplant patient population that will cause donor-derived cell-free DNA levels to change, and that has nothing to do with the allograft status. The existing reported thresholds may not be widely applicable to understudied populations, such as pediatric populations. There's a lot less data in certain populations, such as those that are high immunologic risk, like recipients of ABO-incompatible transplants or those who had preformed DSA. It's unclear whether those patients may just have a higher baseline of donor-derived cell-free DNA because of the higher immunologic risk. And we feel that there is evidence probably to support surveillance monitoring so that you can get a relative change to baseline rather than a one-off test relative to some universal population threshold. But selection of that baseline will be very important. So you should not pick, for example, in the first week post-transplant. That's not an appropriate stable baseline. Again, elevations in donor-derived cell-free DNA are not specific for rejection. It is a rule-out test, and this is supported by the Transplant Society's position statements as well, but is not independently diagnostic of rejection. And at this time, we don't feel that use of donor-derived cell-free DNA as a continuous variable has enough data to support distinguishing different types of rejection. So many publications have suggested that donor-derived cell-free DNA is higher in AMR compared with ACR, but there is still significant overlap between those etiologies, and more work is done needs to be done to determine if that's true in a broader population. So what we would like to see going forward to establish clinical validity is inclusion of more non-rejection cases that are abnormal, especially infection, so we can understand if this is really just a non-specific biomarker of tissue injury, like creatinine or BNP, or if it can tell you a little bit more than those indicators. We also want to see more chronic progressive cases like CAV, vasculopathy, IFTA, and chronic AMR. And as of now, there is very minimal data on whether donor-derived cell-free DNA has any added value in the context of other biomarkers like DSA. We think maybe there could be, and that is one exciting thing in the HLA laboratory. If I could have a DSA test and a donor-derived cell-free DNA test, then I could know, hey, I have a DSA and the graft is injured, this DSA is biologically relevant. As of now, there's very little data on that, but it is emerging. So to get toward clinical utility, which is the last step, we feel currently that there is no data showing that these assays can obviate the need for a biopsy. If you have an abnormal result, you still need a biopsy to figure out what's going on. There is an overall assumption that this minimally invasive monitoring is better for patient outcomes compared with surveillance biopsies. It seems logical, but PROMs and QOLs are not included in clinical trials. So we need to include patient-reported outcomes in clinical trials if we're going to purport that minimally invasive monitoring is better for the patients. In terms of outcomes, there's actually no evidence yet to show that there's an improvement in long-term functional outcomes. And we don't have any data guiding the frequency of surveillance testing. So as of now, the centers that are doing this are doing it according to their own protocols. And we don't have much data understanding the risks that are associated with the testing, which is a critical component of assessing clinical utility. We have to know the risk-benefit ratio. So one possible risk of relying on donor-derived cell-free DNA for monitoring of rejection is a delayed diagnosis in patients who have rejection. If you had a biopsy in hand, you could immediately know what was going on, but if you were doing sequential tiered testing, you could potentially delay diagnosis and actionability for a patient with rejection. So to conclude, there's definitely data that donor-derived cell-free DNA allows you to detect allograft injury earlier than most of the lagging indicators of graft function. Conceivably, this provides an earlier opportunity to intervene and give you better outcomes, which is clinical utility, but currently there's not data on those long-term outcomes. Again, there's a potential reduction in cost in post-transplant care, but most of the studies have not performed a cost analysis. And as we've heard over this whole session, we need standardization and harmonization. Standardization of procedures, standardization of interpretation, and, sorry to the clinicians, but also standardization of actionability of the results. So if we're going to get to clinical utility, which is dependent on intervention, but every center is intervening based on a different threshold or using a different intervention, it's going to be very difficult to wade through all of that variability. This will help us get to clear guidelines to apply the right test to the right patient at the right time and give us a better understanding of what changes in this analyte mean and don't mean, which will guide informed patient management. So thank you all for your attention. I'm happy to wrap up this session, and I look forward to the comments and feedback.
Thank you so much, Nicole, for a very, very clear and easy to follow. Sure, yeah,
Okay.
absolutely.
And I invite, if other members of the working group want to come up here as well, they're welcome. Any questions from the audience?
A great talk, Nicole. Really impressive, and I find it super interesting, all of the things that you were mentioning that affect the assay, particularly kidney size or organ size in general. I'm wondering about organ scarring, particularly because, you know, we have donors who are young with almost no scarring. We have donors who are old, who have a lot of scarring, and over time the kidney accumulates more scarring, which presumably is non-functional tissue, not releasing a lot of DNA. Is there any evidence that that has a role?
So I haven't seen any literature on scarring. Oh, good. Debbie's going to come up. I saw Roy as well. I would just hazard a guess that based on the fact that it's not elevated in IFTA, it may not be elevated in the scarred grafts as well. But Roz is laughing at me. Am I totally wrong?
Is this on? Oh, yeah. No, it's interesting, and I'm not talking about kidney, but in chronic lung allograft dysfunction, or CLAD, you know, it's very interesting because you can see some elevations. But the thing is when you talk about just CLAD or continuing progressive dysfunction of the lung over time, oftentimes there's acute on chronic issues, infection, all those things. And so in lung, there has been papers that have shown that there is an increase in CLAD, but you also have to look, is it clean CLAD with nothing else going on, or is there some evidence of infection or even acute antibody or acute cellular rejection? So it's hard to differentiate that. I don't know in the other organs, but I think we talked about that in the group too, is that there's so many things, but that's a really good question. And sometimes I read the papers and I'm like, did they really say there's nothing else going on? And over time, like 5 years out, most patients of ours have chronic changes. You know, they have chronic lung allograft dysfunction, 50% of them at that time. So it's a good group to evaluate, but again, they're also having other issues. So that's what I heard from that. Thanks.
Thank you very much for that review. That was very helpful. And you may have addressed this, and I stepped in a couple minutes late, but given all of the variability that you pointed out, people's white count changes, organ mass, if I do a dual kidney, I've got twice as much tissue sitting there, variability between lamps, so forth and so on. It seems logical to me that the only valid way, given current limitations, to follow your patient is to follow the absolute value over time. And like you said, in what my center does, we send a DSA every time we're asking this question to try to give us more information before we go for a biopsy needle. Does that seem logical, just following the absolute value over time and comparing the patient to themselves rather than to some standard that doesn't really exist?
Yeah, I think, you know, the population thresholds, the data behind them are really robust. They're just based on registries and a single assay. But again, they have good negative predictive value and not great positive predictive value for rejection. And then you layer on all of these other scenarios where it's like my patient has a scarred graft, my patient has a double kidney, you know, and it's like you can't validate all of those different patient populations. So it seems theoretically that an individual change from baseline would account for that because each individual would have their own baseline. But as I said, right now there's no data guiding standardized surveillance protocols, right? So if you were doing protocol biopsies, then maybe you would replace those with cell-free DNA at your defined time points, but they're not going to be the same as in other centers.
Yeah, thank you.
I want to add to this another point. I mean, it seems really great to compare the patient to his own path over time, but we also have to take into consideration the cost of those tests. And I heard a wonderful presentation by Luke Prochowski, who talked about this, and I think we need to be very mindful of this. So there's a big difference between a test that costs $20 and another test that costs $2,000, and how frequently can we do that on top of all the technical and the validity issues beyond that.
Yeah, so, and just sort of adding on to that, so first, there was a really great talk, Nicole, so thank you. But, you know, just adding on to that, I think it's almost a little the analogies to the previous topic of looking at applet mismatching. I personally think that there is something to cell-free DNA, but I don't order it because I don't know how to use it, and I don't know in what the context should be to order it and what to do with it. So I also think that we'll find it will be useful for monitoring maybe response to therapy in the future, and I know people are doing that already, and it may work in their own individual settings. But until there's a randomized controlled trial done where you do surveillance monitoring in a group that you monitor in a different way, and it's blinded and nobody knows the outcome until you see the result, you don't know that it's going to be something that you can use in clinical practice. That's going to help you care for the patient, that's going to give the patient the outcome that they deserve. So really, I call on the companies that make these biomarkers or make cell-free, that have this assay, to really do the right studies that will enable us to get there, because once and for all, it'll resolve this issue.
Thanks. I just have a question of when these new products come on, the market, like cell-free DNA, even the non-HLA test, the community begins to think that, oh, this is the standard. And then when you try to write literature or get something write something that is contrary to that, but the community thinks otherwise, what do we need to do to kind of go against them? Because I think we've learned that it can be really hard to publish if the community has misconceptions, because the community reviews your work. So what do we need to do as a community to combat that problem that I think is really important in this field?
And my own personal impression is the cat's out of the bag. I mean, it's being used so widely, and then everybody's got the data and feels, oh, I can publish a case series, I can publish a retrospective analysis as observational, and the literature is just kind of flooded with it the same as non-HLA antibodies were. And it's a difficult task to sift through all of that for a meta-analysis, but it should be done, I think, as the next step. We are trying to make recommendations for what an ideal randomized clinical trial would look like to get at clinical utility. Roz stood up first.
Support you as part of the group. The public did review an initial copy of our manuscript and was like, well, we don't need this. Everything she said in this room was, well, we don't need this. We want you to address clinical utility. And how can you do that when you show all of this variability? And it just focusing on this has really made me sort of say, okay, well, it's elevated. I don't know what to do a biopsy, because I can't sort it out. And there's sort of a sense that a negative test is helpful if you're monitoring. But again, I'm happy to give my thoughts about clinical utility, but I can in the context of what I already know that's problematic. So whoever was reviewing our paper, I'd say think about what you're asking the public to do, because we have really smart people in this room. And then the other question was going back to the IFTA issue. Like, if you have a lot of scarring, does that mean your baseline will be different? And again, I think Deb brought this up in CLAD. Same thing, there's no just IFTA, CAN, just laying around. Most of us see inflammation subcapsular, all of the IFTA that we've talked about, and there's cell turnover maybe recipient-derived. I think that we just have to be careful of when we look at these case series. The one thing that I noticed that was discrepant is BK. So the Loop B big group study didn't really see an elevation, but some other studies have. So the question is, how much BK nephropathy did they have, and was it very scarred tissue where there's inflammation, but the whole kidney is really affected? So just a couple of my thoughts.
I think, sorry, go ahead, Debbie.
Oh, no, I was actually answering what Carrie was saying. When you're talking about getting it out to the community, who is the community? And what I think is this is an amazing group right here. And every single one of these people here have read STAR 22. They know what's going on. What I really think has to happen is for this information to get out to the clinicians, the young clinicians who see papers on 9-HLA and I'm going to test it, I'm going to treat everybody I have, or using different new tests. And I wonder how we can best get this information to people who may not, they may just be very, very busy clinicians, see some great articles in the journals, but how do we get them the meat of it from what I try to put all your recommendations from 22 in all of my lectures, and they're like, where did you get this? I'm like, so how do we, I think our job in this room is how do we promote what's been taught and learned here? Thanks.
I think this is a fantastic point, Debbie, and thank you for bringing it. I think it's relevant for all the different topics, not just cell-free DNA, and I would look for input from all of you. I think that one of the things that I find myself struggling with is there were all those publications out there that people had put, some of them really high impact literature, and then you start looking at the methodology and you realize that there are methodological flaws, whether it was how they test HLA antibodies or non-HLA antibodies or cell-free DNA and so on and so forth. So yeah, how do you deal with the cat is already out of the sack? And I would love to hear more from this, but I think one of the things that would be really great that hopefully can come in collaboration between the AST and ASHI is to have some guidelines of when you test things and how you do things. One of the things that Nicole had brought up before is trying to get editors of different journals requiring, when you're putting your methods, put all those information. And I think more than anything else, it's incumbent on us, not on the young generation, to teach the young generation how to critically review papers. It's not enough to read the abstract and run to the clinic and go ahead and implement it. It's not even enough to read the discussion. I teach my students, start with the methods. Go through the methods and make sure that the essay was done or the study was done properly. And if you have no knowledge about how to run that assay, go and ask your colleague who is a professional in this particular field, does this approach, are these methods reasonable for the study that you do? I'll take it a step back. I don't know that we can have an impact on this, but I think this is something that people need to be taught in elementary school and in high school. Fine, okay. When they go into college, right, not to finish medical school and sit here after 20, 30 years of being in a field and say, hang on, but we haven't thought about all those things. So I think those will be my parting words. And Carrie, the stage is now.
Say something a little bit controversial. There's a lot of money being made, a ton of money being made off of these assays, and that money has bought access. And that access is why it's why the assay is used and why it's so difficult for us to prevent its being misused.
Yeah, thank you. No, this is a great discussion. Really appreciate everyone who is here. So the overall plan is to take this, hopefully get a manuscript out soon. But no, this isn't not the end. This is just, hey, where we are now. And the hope is that we'll have this again in, 2028? Seems a long time away, but that's the plan. And so really to report on where we are now. interested in input. If anyone has comments or questions, happy to share my email or others, that we would be happy to take ideas for what we can discuss in STAR, or other people who might have some potential interest in the working groups or ideas. We can't include everyone, unfortunately. And the other thing, I think, going back to how do we disseminate the knowledge, if people have ideas of how we can disseminate the knowledge, really open to ideas there, because I think that's a great point. What's the point of us discussing if it doesn't go to the community?